Carotid artery disease, vascular nursing basic training. Hello, my name is Chris Owen, and I am pleased to welcome you to this training on carotid artery disease. The focus of this training is for the vascular nurse. In this series of modules, I will review the anatomy and the atherosclerotic changes that occur in the arteries of the neck. I will also review the necessary physical examination and the diagnostic studies that will be performed to determine severity of disease. Finally, the medical and surgical, nursing education, and management of this patient population will be reviewed. At the end of this module, which is composed of several units, the vascular nurse will be able to describe cerebrovascular anatomy and understand the atherosclerotic changes of the carotid artery and relate risk factors and etiology, perform an appropriate assessment, and understand the types of diagnostic studies, manage a patient with carotid artery disease, and provide patient education. Unit 1 includes the etiology, atherosclerotic changes of the carotid artery, risk factors, and anatomy associated with carotid artery disease. Unit 2 includes the clinical presentation, assessment, and diagnostic studies pertinent to determine severity of carotid artery disease. Unit 3 includes the medical and surgical management, and Unit 4 includes the nursing management and patient education for carotid artery disease. Unit 1 of the module on carotid artery disease will include the etiology and atherosclerotic changes, risk factors, and anatomy associated with carotid artery disease. Stroke is the third leading cause of death in the United States and the leading cause of serious long-term disability. Between 2012 and 2030, total direct stroke-related costs are projected to triple, from $71.6 billion to $184.1 billion, with the majority of the projected increase in costs arising from those ages 65 to 79 years. This represents a significant source of morbidity and mortality. Atherosclerosis is the cause of 1/3 of all strokes, and approximately 50% of strokes occur in the distribution of the carotid arteries. The most common etiology of carotid artery disease is atherosclerosis and accounts for 90% of extracranial vascular disease. Atherosclerosis is common throughout the vascular tree. The carotid distribution is not an exception. Artery walls are made up of 3 layers: the intima, media, and adventitia. The intimal lining is a single layer of endothelial cells resting on a connective tissue layer. The endothelium, which is a collective term of all the endothelial cells, is the layer that lines the blood vessel and is in contact with moving blood. An atherosclerotic lesion begins to develop as lipoproteins accumulate in the intimal lining. Oxidative changes occur, and cytokines facilitate monocyte invasion into the wall of the artery. These monocytes become lipid-laden macrophages, or foam cells. Smooth muscle cells migrate into the intima and proliferate. Extracellular lipids accumulate in a central core covered with a layer of connective tissue called the fibrous cap. This is how plaque develops. Atherosclerosis causes ischemic symptoms by embolization and thrombosis. An ulcerated lesion occurs when the lining of the artery, the endothelium and fibrous cap, ruptures, exposing cholesterol deposits, which can then become emboli to the brain. Atherosclerotic plaque occurs at places where flow divides and branches due to turbulent flow. Therefore, the bifurcation of the common carotid artery into the internal and external carotid arteries is a common site of plaque formation. Identification of individuals with carotid disease can help identify people at higher risk for stroke. 80% of strokes are preventable, per the National Stroke Association. The key to stroke prevention from carotid disease is the management of atherosclerosis risk factors. Hypertension should be aggressively managed. According to JNC8, most blood pressures should be less than 140/90. Individuals should know their cholesterol levels, LDL, HDL, triglycerides, and total cholesterol. Ideally, the level of bad cholesterol should be below 100 milligrams per deciliter. Individuals should know their likelihood of getting diabetes and have a hemoglobin A1C level of less than 7%. Tobacco use and smoking is a profound risk factor for vascular disease. Smoking doubles the risk of stroke. It damages blood vessel walls, accelerates atherosclerosis, and raises blood pressure. Obesity and physical activity are linked. The goal is to be physically active 5 days a week. Maintaining optimal weight reduces the risk for stroke and other circulatory disorders. The incidence of stroke increases with age. We have seen that women have a higher incidence of stroke and a worse prognosis than men. Family history of stroke is a key risk for the development of carotid artery stenosis. Previous stroke, or TIA, increases the risk of subsequent stroke. A patent foramen ovale is found in 1 of 5 Americans. It is a remnant of the fetal foramen ovale that should have closed at birth. An atrial septal defect, which is found in the septum between the right and left atrium, can put someone at higher risk for stroke or TIA. PFO and ASD can be found on an echocardiogram. Less common, but other known carotid artery disease include fibromuscular dysplasia, which is a condition that is characterized by fibromedial and intimal hyperplasia that leads to focal stenosis. These stenoses are common in the internal carotid arteries and can be seen in the vertebral arteries. These focal lesions are amenable to intervention and stenting. Irradiation for head and neck cancer can damage vessel walls and cause proliferation of atherosclerosis. Carotid surgery is usually indicated with progressive disease. Carotid artery dissection is seen with blunt trauma, sudden extension of the neck, and violent coughing or vomiting. It's a tear in the intimal lining, usually seen in patients less than 50 years old who have a history of fibromuscular dysplasia or in people with hypertension. Carotid dissection is a breakdown of the layers of the carotid artery that cause the wall to tear. The tear may cause stenosis, an irregular narrowing of the opening in the vessel, and occlusion, a flap of the vessel wall protruding into the opening. Hyperextension of the neck from turning of the head is a common cause of carotid dissection, as the action can stretch the internal carotid artery over the spinal vertebrae. Other traumatic causes include chiropractic manipulation, attempted strangulation, and cerebral angiography. Now I'll discuss anatomy of blood flow to the brain via the great vessels. The most common aortic arch is present in this diagram. The aorta is the largest vessel in the body. Oxygenated blood exits the left ventricle through the aortic valve into the ascending aorta. Just beyond the aortic valve is where the coronary arteries are perfused. Blood continues up the ascending aorta to the aortic arch. The brachiocephalic, left common carotid artery, and left subclavian artery originate separately from the aortic arch. This is seen in approximately 85% of individuals. The brachiocephalic or innominate artery bifurcates to become the right subclavian artery, which feeds the right arm. Off the right subclavian artery, which is not pictured, arises the right vertebral artery. The second branch off the innominate is the right common carotid artery. This bifurcates into the right internal and external carotid arteries. Along the arch of the aorta rises the left common carotid artery, which bifurcates into the left internal and external carotid arteries and the left subclavian artery. The left vertebral artery arises from the left subclavian artery and feeds to the left arm. In the intracranial space, the right and left carotid arteries give rise to the posterior communicating artery, which connects the circle of Willis with the posterior cerebral artery that arises from the vertebrobasilar circulation. The internal carotid artery bifurcates into the anterior cerebral and middle cerebral arteries. The anterior cerebral arteries connect with the circle of Willis through the anterior communicating artery. The posterior circulation communicates via the posterior communicating artery with the carotid system via the posterior communicating arteries and through the circle of Willis. Collateral pathways are common. Key collateral pathways are from the external carotid artery to the internal carotid artery, external carotid to the vertebral artery, and others. Of note, it is believed that only 50% of all people have a complete circle of Willis. This is another picture that demonstrates the bifurcation of the common carotid arteries into the internal and external carotid arteries. The anterior two-thirds of the brain's blood supply is provided by the carotid circulation. The internal carotid arteries supply blood to the anterior and middle cerebral arteries and give rise to the circle of Willis. The first branch off the internal carotid artery is the ophthalmic artery. Emboli to this branch can cause amaurosis fugax, which will be discussed later in this presentation. The first section of the internal carotid artery is called the carotid bulb or sinus and contains the baroreceptors that regulate blood pressure and chemoreceptors that detect carbon dioxide in the blood. The external carotid artery and its branches supply blood to the face, scalp, skull, nasopharynx, and meninges. The posterior circulation is supplied by the vertebral arteries. The vertebral artery carries blood to the brain and spinal cord. The vertebral artery enters the skull through the foramen magnum. The branches from this artery feed the cervical area and the deep structures of the neck. Once inside the cranium, the left vertebral and right vertebral arteries merge and become the basilar artery. The basilar artery supplies the brainstem, cerebellum, and occipital lobes. Surgery to the vertebral system is limited because the artery enters the cervical spine. This concludes the first unit of the module on carotid artery disease.